Hi, my name is Dr. DJ Heusler, and welcome to Vet Candy program in ophthalmology. Hi, I'm Dr. DJ Heusler, and this is our module on lens disease in veterinary ophthalmology. What we're going to cover during this module is basic anatomy, diagnostics, nuclear sclerosis, cataracts, cataract surgery, lens subluxation, anterior lens luxation, and posterior lens luxation. So obviously this is a drawing or cartoon representation of gross anatomy of the eye. And again, with this module, we're going to be focusing on the lens. So as it relates to the lens regarding anatomy, we're going to be discussing the anterior epithelium, the posterior epithelium, the nucleus, the cortex of the lens, as well as the equator. As with any ophthalmic presentation to your practice, we should always be doing a complete ophthalmic examination. And what that involves is Schirmer tear testing, tonometry, fluorescein staining of the cornea to look for ulcers, evaluating Menis responses, evaluating dazzle responses, and evaluating pupillary light reflexes. We should be looking at the anterior portion of the eye, as well as doing a full fundus examination of the posterior aspect of the eye. If a patient has any concern for lenticular disease as they present to your practice, you should always be obtaining intraocular pressures. Nuclear sclerosis is a normal age-related change that's seen in dogs. It's typically seen in dogs about 6 years of age and older. The nucleus becomes more dense, but does not restrict vision for the patient. The dog should not be experiencing vision problems. The veterinarian should be able to obtain a clear fundus examination. And again, this is not a cataract. So here are some different examples of what nuclear sclerosis looks like. It is more dense. You should be able to get a clear view of the fundus on a fundus examination. And the easiest way to evaluate nuclear sclerosis is to make sure that you're dilating your patients. So it is useful to use tropicamide, give them a drop in each eye, and then as long as they don't have increased intraocular pressures, and then have them wait in the lobby for about 15 to 20 minutes before performing the complete examination. A cataract is an opacity to the lens that causes vision impairment. It occurs in any age of dog, and it also occurs in any purebred or mixed breed dog. So here are some various examples of cataracts, and they can range anywhere from incipient to early immature, late immature, mature, and hypermature cataracts. So as we see here, with an incipient cataract that typically takes up less than 10% of the lens, an early immature cataract takes up about 11 to 50% of the lens, a late immature cataract takes up about 51 to 99% of the lens, a mature cataract covers 100% of the lens, and a hypermature cataract is where we start to get some resorption of the cortex and the lens. You get a little bit of a tapetal glow. There's some capsular wrinkling, and they look a little bit more sparkly compared to the other cataracts. Lastly, there's a Morgagnian cataract, and that is where the cortex has completely resorbed and the nucleus sinks to the bottom of the lens capsule. Various causes of cataracts include inherited cataracts, cataracts caused by diabetes, senile cataracts, cataracts caused by radiation therapy, nutritional cataracts such as hypocalcemia, cataracts caused by progressive retinal atrophy or PRA, cataracts caused by lens luxation, cataracts caused by uveitis, cataracts caused by electrocution, and then cataracts caused by drugs or toxins such as ketoconazole, and lastly would be cataracts caused by trauma. So what does a cataract do for vision? The purpose of the lens is to converge beams of light and the image onto the retina in a specific place in order to project that image to the brain. However, with a cataract, the cataract will scatter those lights and images across the back of the retina, and it will also obstruct vision for the patient. So in this study by Klein et al., they looked at various post-operative complications and visual outcomes in patients. 83% were functionally visual at the end of the study. 10% were blind and 7% had a decreased vision. Complications that were seen in this study were post-operative ocular hypertension, corneal lipid, uveitis, intraocular hemorrhage, retinal detachment, and glaucoma. And in this study, Boston Terriers showed a decreased success rate as compared to other breeds. So in this study by Lim et al., it also looked at complications in cataract surgery. They had a 90% success rate in this study, with complications being posterior capsular opacification. Retinal detachment was found in about 1 to 2% of cases. Glaucoma was found at about 10% in cases. Prevalence of failure was less than 10% at a 3-year follow-up. Boston Terriers, Cocker Spaniels, Poodles, Shih Tzus were at a more of a risk of glaucoma, and hypermature cataracts increased the complication rate, which means that we should really be trying in veterinary medicine to refer patients before they get to be a hypermature cataract. So whenever I'm looking at some of these studies, I always ask myself if that's what is real life for me in my practice, and so I evaluated cataract patients over the last 10 years, and over 1,800 cataract surgeries, sure enough, sits right at about 90% success rate. So these are both adequate numbers to quote for patients in terms of success rates. So in this study by Siegel et al., this showed in their patients they had a 90% success rate. Complications that were seen were posterior capsular opacification. A retinal detachment was seen in about 1 to 2% of cases. Glaucoma in less than 10% of cases. The prevalence of failure was less than 10% at the 3-year follow-up. Boston Terriers, Cocker Spaniels, Cocker Poodles, Shih Tzus were at more of a risk of glaucoma as compared to other breeds. And hypermature cataracts increased the complication rate, which means that as a profession, we should be referring these cases before they reach a hypermature state in order to give the patient the best chance of long-term vision. So whenever I evaluate these studies, I always think if these are consistent with my practice. And sure enough, over the last 10 years, evaluating cataract patients post-operatively with over 1,800 cataract surgeries, it does come out right around 90% success rate. So prior to admitting a patient for cataract surgery, we have to run some preoperative diagnostics on them. We perform a complete blood count as well as biochemical profile. We perform a urinalysis. We perform a urine culture as long as they are a diabetic. If they're not a diabetic, we don't necessarily perform a urine culture. And then we measure their blood pressure prior to surgery. We always perform an electroretinogram on the eyes that are undergoing surgery. And what we're looking for is to whether or not this eye is to cut or not to cut. So should we proceed with surgery or should we fail this patient and not proceed with surgery? We're looking to see if they are normal, which is this waveform right here, where the wave drops down first, then comes up, and then drops down again like this. And we're also looking at whether they have progressive retinal atrophy or sudden acquired retinal degeneration syndrome, which would show up on an ERG like this, where the trace is a flat line. We ultrasound the eyes in order to look at the size of the lens, to evaluate if there's any retinal detachments, to evaluate if there's any lens capsule ruptures, any vitreal consolidation, or any potential for intraocular tumors. So as you can see here are some ultrasound images of various patients with retinal detachments. So in terms of the cataract surgery process, we first make a 3mm incision, which is made at the limbus. The anterior chamber is replaced with viscoelastic in order to inflate the anterior chamber. An anterior capsulotomy and then a capsulectomy is performed in order to gain access to the inside of the lens. The lens is removed via phacoemulsification, and then lens epithelial cells are removed from the capsule via irrigation and aspiration. An IOL is then inserted into the capsule, and viscoelastic is then removed with irrigation aspiration, and then we close the incision with 9/0 Vicryl. Here are some various images of artificial lenses or IOLs that have been placed into patients, and these are what reestablish vision back to normal for each patient. So aftercare. Aftercare is pretty intense for the first couple weeks after surgery. They're sent home on topical antibiotics. My choice is typically ofloxacin, and that's 4 times per day. Send them home on oral antibiotics such as Clavamox. They're sent home with topical NSAIDs. Flurbiprofen or diclofenac are both acceptable, and they're typically dosed at 4 times per day. Oral NSAIDs such as carprofen, a topical lubricant, a protective e-collar, restricted activity, and then we check them again in about 2 weeks. Over the course of a year, we reduce their medications over time. However, these patients do have lifelong follow-up and medications. We typically try to get them down to a drop that's just once or twice a day, lifelong, in order to reduce inflammation, which helps to reduce chances for complications such as retinal detachment or glaucoma. We always advise that low-fat diets and low-fat treats are to be used for diabetics. So the question is always, when do we refer these patients? Well, the sooner the better the outcome. Allowing the lens to mature or to ripen is no longer appropriate. Diabetics especially need to be referred quickly due to the risk of lens capsule rupture, retinal detachment, glaucoma, and uveitis. Diabetic schnauzers need to be referred very quickly due to the risk of lens capsule rupture. And here on this picture, you can see that this patient has a lens capsule rupture with quite a few chorotic precipitates, and this patient was referred a little bit too late in this case. So let's say you see a patient in your practice with cataracts. What can you do to get them started? Place each patient with cataracts on topical flurbiprofen or diclofenac once or twice daily prior to the referral. So there are quite a few drops that are marketed online as to cure-alls for cataracts or reduction in cataracts, and most of them are nutraceuticals that are not backed by research. These do not help cataracts at all. The only thing that will remove a cataract is through surgery. So there are many products on the market. Many are proprietary blends of unlisted ingredients, and again, nutraceuticals are completely unregulated, and most are not backed by research. And at most, what you're doing for your client in this regard is just wasting their money. In this study by Williams et al. Evaluating N-acetylcarnitine as it relates to cataracts and removal of cataracts, the evaluation of lens opacity was evaluated via digital image processing. Approximately 2% improvement in lens opacity. However, 75% of owners reported improved vision. No clinical evaluation of lens opacity was performed. There was no placebo, and it was an unmasked trial. So unfortunately, I would say that there was quite a placebo effect with these owners in terms of giving these patients these medications. So do they work? Well, there may be some minimal effect of reversing early changes to crystallines in the lens, but you can't undo lens density changes. You cannot undo lens fiber disorganization, and you cannot undo cellular lysis. So any benefit of these types of drops would be limited to senile cataracts. So the cost to benefit, well, they're about $50 to $100 per bottle, and they're not doing much. The analogy that comes to mind as cataracts is as proteins are shifted, it is the equivalent of taking a raw egg and cooking the egg. The proteins are changed. However, you can't take that cooked egg and turn it back to a raw egg, and that's the same thing as how cataracts are formed. So let's talk about lens subluxations now. Here are a variety of lens subluxations where the lens is starting to shift out of the patellar fossa. And in many of these cases, you can see the aphakic crescent, or the space that is in between the lens equator and allowing you to see through the pupillary margin. There are many causes of lens subluxations: congenital, primary. Primary cases are typically inherited, and these will occur in the patient between about 3 and 6 years of age. There are secondary causes such as glaucoma. As that lens, as that globe becomes larger or buphthalmic, it stretches and the zonules break, and you can develop a secondary lens subluxation. And then uveitis. Uveitis can also cause lens subluxation as it starts to degrade and erode the zonular fibers that hold the lens in place. And lastly, trauma can also cause a lens subluxation. In this study by Overbauer et al., Inheritance of Cataracts and Primary Lens Luxation in Jack Russell Terriers, this was found that lens luxations and subluxations are inherited in Jack Russell Terriers, and it is due to a mutation in the HSF4 gene. Other breeds found to have inherited primary lens luxation include the Sealyham Terrier, wire-haired Fox Terrier, Mini Bull Terrier, the different terrier crosses, Tibetan Terriers, and as well as Shar-Peis. The ideal management of lens subluxations is surgical removal of the lens with or without IOL placement. Placing an IOL is largely dependent on whether the capsule is stable enough to put an artificial lens into the eye. Alternatively to surgery, a miotic can be used if the lens is posterior subluxated. using medications such as latanoprost or democarium bromide. That creates a miotic pupil which traps that lens into the posterior segment, preventing an anterior lens luxation. In this study, outcomes of non-surgical management and efficacy of democarium bromide treatment for primary lens instability in dogs over 34 cases by Binder et al. At 4 to 6 weeks and 3 months post-diagnosis of lens instability, 100% of dogs retained vision when being treated with democarium bromide. At 1 year post-diagnosis, 80% retained vision, and at 2 years post-diagnosis, 58% of the patients retained vision. So let's talk about anterior lens luxations in dogs. This occurs as a primary lens luxation in the dog. And what happens is the lens moves forward out of the patellar fossa and into the anterior chamber. This is caused by general breakdown of the zonular fibers that hold the lens in place. This can cause a rapid increase in pressure in the eye, which can cause blindness, mild to moderate to discomfort to severe pain. So treatment of anterior lens luxations includes an intracapsular lens extraction. And how we do this is we make a 160-degree incision across the cornea. The vitreal attachments are severed from the lens, and the lens is removed from the anterior portion of the eye. A partial vitrectomy can be performed. And we have to keep in mind, though, that a large incision increases the risk of infection within the eye. There is an ongoing risk of retinal detachment due to vitreal degeneration, and there is a risk of glaucoma. We leave these patients aphakic, meaning that they do not have a lens or an artificial lens in the eye. And in that particular lens that is aphakic, they see items at distance fairly well, but they may struggle with some vision up close. So if you had a patient that had both lenses removed, they would struggle with treats on the ground, maybe some catching popcorn out of the air or bumping into some objects up close to them, but they seem to see squirrels and other animals out in the yard at a distance fairly well. So let's say you have one of these patients with an anterior lens luxation present to your practice. What can you do to get them started in the right direction? So you can start the patient on dorzolamide or dorzolamide timolol 3 times a day if the intraocular pressures are greater than 25. Keep in mind, do not give them any miotics. Do not give them latanoprost, do not give them democarium bromide, and do not give them pilocarpine. Otherwise, this will cause the pressures to increase further. You can also administer flurbiprofen or diclofenac once to twice daily to decrease subclinical uveitis caused by the lens bumping into other intraocular structures, and you want to refer these immediately as they are considered to be ophthalmic emergencies. So what else can you do, and what other considerations are there? Well, is this patient visual? Does the patient have a dazzle response? If the patient is painful, has increased intraocular pressures, no menace response and no dazzle response, and referral is not an option for them, then in order to alleviate the patient's pain, enucleation is appropriate. If nothing is done, the intraocular pressures are normal, and the lens remains anteriorly luxated, endothelial decompensation can occur, and this can result in corneal rupture. So here are 3 different pictures of posterior lens luxations. In each one of these pictures, you can see the lens located behind the iris and a large aphakic crescent. In the photo with the retina, you can see the lens is actually laying against the non-tapetal aspect of the retina. So how do we manage posterior lens luxations? Well, they're difficult to remove surgically, depending on which technique that you prefer. I personally prefer to visco-float the lens out with either a 1.8% viscoelastic or a 3% viscoelastic if the 1.8% doesn't work. There's a high risk of retinal detachment if the lens is removed or if the lens even stays in the vitreous. As that lens moves around the vitreous, it creates different tensions on the vitreous, and this can detach the retina. There's a high risk of retinal detachment if the lens is removed surgically because you're putting surgical instruments into the back of the eye where the retina is in order to remove this lens. There's a high risk of glaucoma if the lens migrates anteriorly. If the lens is posteriorly luxated, you can prescribe a topical miotic such as latanoprost in order to trap the lens into the posterior segment. These patients typically do not see well, but comfort can be maintained for longer than an anterior lens luxation patient. So that concludes our module on lens and lenticular disease in veterinary ophthalmology. Thanks for watching. This concludes the ophthalmology program brought to you by Centrix. The next step for you is completing this process by passing a quiz. In the comments below, you will see a link to this quiz. Once you pass the quiz, you will receive a certificate of completion and another link that will direct you to tools to celebrate, recognize, and share your accomplishment. If you have any questions, please email us at hello@myvetcandy.com. Don't forget to like, comment, and share. Thank you again for watching.